Thank you, Heem, today for contacting me to talk a little bit about pituitary iron in transfusion-dependent sickle cell disease patients. I am Akhila Vadivelan. I'm a fellow physician at UCLA. I'll be talking to you guys about the research which was primarily conducted in Children's Hospital of Los Angeles under my mentors, Dr. John Wood and Dr. Thomas Coates. So to give you an overview, blood transfusions still play a very relevant role in today's medicine. Most hemoglobinopathies, such as the sickle cell disease and the thalassemia patients, are dependent on iron transfusions. Blood transfusions. So with each ml of blood, there is 0.8 milligrams of iron which goes into the body. The problem within the human body is there's no way to excrete this excessive iron. So what happens to this excessive iron after the bone marrow takes up all the iron for making new blood cells? So this excessive iron goes in deposits into various other organs, such as the pancreas, the pituitaries, and the heart even. So in the pituitary, it can cause pituitary dysfunction and can lead to gonadal dysfunction. In the pancreas, it can lead to diabetes, and while in the heart, it can even lead to heart failure. So over the past years, what they've done is they've used a liver biopsy to quantify how much the body has this excessive iron. But with the advent of MRI, as you know, it's magnetic and iron can be detected through it. So MRIs have been the standard of care to detect how much iron is there in the human body, which is excessive, and it can be quantified in each of the different organs as well. So this study basically focuses on trying to see what determines the what is the prevalence, the predictors, and the significance of pituitary iron in the chronically transfused sickle cell disease patients. We did a cross-sectional study of all the sickle cell patients who had undergone a brain MRI between 2009 and 2022. And we included MRIs that had a pituitary volume and iron, and also we checked for liver, pancreas, and the heart iron. We excluded patients with a bone marrow transplant because conditioning regimens used for bone marrow transplant can cause hypogonadism regardless of the iron status. And we also chart reviewed for various other labs, etc. Surprisingly, what we found was 73% of the patients had pituitary iron, and about 27% of them were in the range which is associated with hypogonadism, as we saw it in the thalassemia patients. The best overall predictors for severe pituitary iron were the liver iron concentration and the ferritin, with an area under the curve of 0.92 and 0.91. However, the best multivariate predictor was the ferritin and the years of transfusion therapy, with a combined area under the curve of 0.96, which is very relevant. We also found that there is a relationship between the pituitary iron and the pituitary volume. We saw that the pituitary was smaller in those patients who had higher pituitary iron. And we also found that the FSH levels, which is a hormone secreted by the pituitary, is lower in those patients with higher pituitary iron. So this study is really remarkable in the sense that we were able to figure out that the patients also were younger and they had pituitary iron even before pancreatic iron, which was not found before. And however, none of our patients had a clinical diagnosis of hypogonadism, but the suggestion that the FSH is lower with higher pituitary iron only means that it can get worse over time. So we encourage all clinicians to keep a high index of suspicion for iron overload mediated hypogonadism in the chronically transfused sickle cell disease patients. So the pituitary iron in thalassemia patients is way worse than in the sickle cell disease patients, because thalassemia patients get transfusions much earlier in life, and they also have ineffective erythropoiesis, which means that they're not able to utilize all the iron that we give through blood transfusions for making red blood cells. But the sickle cell patients are able to use the iron given through blood and through the blood and are able to make red cells efficiently. So the thalassemia patients, the pituitary iron is detectable as early as 7 years. And then by the time they're in the second decade of life, many of them don't achieve puberty or they have some sort of gonadal dysfunction by the time they're 20 years of age, which is not seen in the sickle cell patients, which we anticipate can be seen maybe in their 40s. Yeah. Yeah, the pancreatic iron, which is also different from the pituitary iron, between the thalassemia and the sickle cell disease patients. So the second paper where we're looking at the pancreatic iron in the sickle cell disease patients, very few of them had any form of glucose dysregulation compared to the thalassemia patients who had a very high amount of glucose dysregulation and also had diabetes. And this is also primarily because of the non-transparent bound iron, which is super high in the thalassemia patients as compared to the sickle cell disease patients.